Hi everyone, welcome to ilovepharmacology. In this session, we're going to learn about the cholinergic drugs, which is also known as cholinomimetic agents. So these are the questions that needs to be answered at the end of this session. You can go through it. So coming to the case scenario, a 25-year-old woman presents to the general medicine clinic complaining of vision problems. She has difficulty in keeping her eyes open and complains of seeing double diplopia. Her symptom fluctuates throughout the day. Her ptosis is more common in the left eye but will shift over to the right eye. Her symptoms are generally better in the morning and worsen as the day progresses. Her ptosis seems to get better after she takes the rest for her eye. She exercises regularly but has noticed that over the past 2 months she has struggled to complete her evening run due to fatigue in her hips. You suspect myasthenia gravis, so you make a diagnosis as myasthenia gravis and perform a hydrophonium, which is also called as stencilon test. The test is positive, therefore the patient is started on pyridostigmine. So here the question that needs to be answered is, how does the hydrophonium test aid in diagnosis of myasthenia gravis? What are the mechanism of action of hydrophonium? What are the mechanism of action of pyridostigmine? So let us answer all these questions at the end of this session. So coming to the muscarinic cholinomimetic agent, the specific learning objectives will be you should be able to lease the receptors of parasympathetic nervous system. Even you should be able to contrast the actions and effects of direct and indirect stimulation of muscarinic cholinereceptors. And also you should be able to lease the therapeutic uses of parasympathomimetic agents and also the associated adverse effects. So coming to the parasympathetic nervous system, as you know that the anatomical division of the autonomic nervous system can be divided into sympathetic nervous system and the parasympathetic nervous system. So usually the nervous systems are divided into peripheral nervous system and the somatic system, and in the autonomic nervous system you have got sympathetic nervous system and parasympathetic nervous system. So these parasympathetic nervous system, the preganglionic fibers are carried on cranial and the sacral spinal nerve to get synapsed on the ganglion that give rise to the short postganglionic fibers. Whereas in the sympathetic nervous system, it had a long postganglionic fibers, whereas parasympathetic nervous system will have a short postganglionic fibers. And coming to the cholinomimetic agents. So cholinomimetic agents means these are the drugs which mimics the action of acetylcholine. They act directly as well as indirectly by activating the cholinereceptors. So directly acting agents, we have a pilocarpine, bethanocol and carbachol are designated to act selectively on either the muscarinic receptor or the nicotinic cholinereceptor. So indirectly acting agent, we have a drugs like neostigmine, physostigmine, hydrophonium and demecarium, which are going to inhibit the acetylcholinesterase enzyme that is responsible for acetylcholine metabolism, which can act on both the receptors. So pilocarpine is a directly acting cholinomimetic agent that acts chiefly at muscarinic receptors. Additionally, the pilocarpine as well as other cholinomimetic agent can be used in the treatment of glaucoma in the form of topical preparations in the form of eye drops. So coming to the other details, the afferent nerve releases the neurotransmitter acetylcholine at both the places, that is the preganglionic as well as the postganglionic nerve endings, and also at the somatic nerve endings. The acetylcholine released from the nerve endings will going to interact with the cholinereceptors, and they can be classified either nicotinic or muscarinic actions after the alkaloids initially used to distinguish them. So coming to the cholinereceptors. So nicotinic cholinereceptors are localized mainly at the all the postganglionic neurons, that is the autonomic ganglion as well as adrenal medulla, and also in the skeletal muscle end plates which are innervated by somatic nerves. So muscarinic cholinereceptors are localized mainly at the organs innervated by parasympathetic postganglionic nerve endings. They are present mainly on the cardiac system, sinoatrial SA node, AV node, and activation can lead to negative impact, that is negative chronotropic effect, negative dromotropic effect, delayed AV conduction. So what happens when cholinergic stimulation happens to muscarinic receptors? So usually this muscarinic receptor activation in the smooth muscles in the exocrine glands as well as vascular endothelium will lead to smooth muscle contraction leading to bronchoconstriction, increased acid secretion from the exocrine glands, as well as it causes vasodilation through endothelial derived relaxing factor release, which releases the nitric oxide from the vascular endothelial cells. So again, there are two types of receptors under nicotinic cholinergic. They are NN, which are localized postganglionic neurons, and NM receptors, mainly localized in the skeletal muscle end plates. Whereas muscarinic cholinergic, we have 5 subtypes M1 to M5, and M4 and M5 are located only in the CNS, whereas M1, M2, M3 are located in the sympathetic postganglionic neurons in the CNS, AV node, SA node, as well as the atrial muscles, smooth muscles, exocrine gland, and vascular endothelium that does not receive the parasympathetic innervations. So what are the effects of directly acting cholinergic stimulants? On the eye, they are present on the sphincter muscles of the iris, which leads to contraction, that is miosis. Ciliary muscle contraction will lead to contraction for near vision. It helps in accommodation. In the heart, SA node activation of M2 receptor will decrease the heart rate, negative chronotropic effect. On the atria, decrease the contractility, negative inotropy, as well as it decreases the refractory period. And in the AV node, it decreases the conduction velocity, that is negative dromotropic effect. So activation of M2 in the heart, it has got the depressant action on the heart. And ventricles, there is a small decrease in the contractile strength. So blood vessels in the artery and veins, it causes dilation through the release of nitric oxide from the EDRF, and it can cause constriction, vasoconstriction only at the high doses, which has got direct effect. On the lung, contraction of the bronchial smooth muscles will lead to bronchoconstriction, bronchial gland secretion will be increased, and gastrointestinal tract, the motility will increase, the sphincter will relax, and secretions will be more. On the urinary bladder, the detrusor muscle will contract, trigone in the sphincter will relax, it helps in voiding. On the glands like sweat, salivary, lacrimal, nasolacrimal, it increases the secretion. So coming to the muscarinic cholinomimetic agents, they can be classified into directly acting cholinergic muscarinic receptor agonist as well as indirectly acting muscarinic agent. So under directly acting, we have two groups. One is acetylcholine and their synthetic cholinesters, namely as acetylcholine, methacholine, carbachol, and methanocol. And second group is the cholinomimetic. These are the alkaloids which are derived naturally like pilocarpine, muscarine, and the aracholine. And indirectly acting muscarinic agent, they basically inhibit the metabolism of acetylcholine by blocking the acetylcholinesterase enzyme. Thereby it increases the availability of acetylcholine at the synapse. So acetylcholine inhibitors are commonly used in autonomic pathologies. These are physostigmine, neostigmine, pyridostigmine, and amidomium. So coming to the clinical uses of cholinomimetic agents. So cholinomimetic agents like directly and indirectly acting parasympathetic agents, they have many clinical use. So primarily pilocarpine, methanocol, neostigmine are used widely in clinical practice. They can be used in the treatment of glaucoma. Pilocarpine, physostigmine, they are used in acute angle closure glaucoma. They are also used in case of treatment of postoperative urinary retention or postoperative paralytic ileus, and also in case of dry eye, that is xerostomia, Sjogren syndrome, and also in myasthenia gravis to increase the muscle activity. So acetylcholine is generally not used clinically. What could be the reason? The reason is it gets rapidly metabolized or rapidly hydrolyzed by the plasma acetylcholinesterase and the pseudocholinesterases. So adverse effects of cholinomimetic agents are usually it is due to the excess of cholinergic activity, which causes diarrhea, salivation, increase in sweating, bronchoconstriction, vasodilation, which can lead to fall in blood pressure, flushing, bradycardia, and the respective receptors which are mediated are given in the bracket. And nausea and vomiting are also common. So what will be the adverse effects of cholinesterase inhibitors? So usually the cholinesterase inhibitors, like they result as a result of toxicity from pesticides like organophosphate, they can cause muscle weakness, convulsions, and the respiratory failure. So let's know the structure of acetylcholine. Acetylcholine is basically a choline ester which is not very lipid soluble because of its charged quaternary ammonium group which will not cross the blood-brain barrier. Basically, it interacts with both the muscarinic and nicotinic cholinesterase, and choline esters like carbachol, methacholine, and the methanocol, they have similar structure to that of the acetylcholine and are used clinically. Unlike acetylcholine and carbachol, methacholine and methacholine are very highly selective for muscarinic cholinesterase, whereas pilocarpine can cross the blood-brain barrier because of its tertiary amine alkaloid. Coming to the mechanism of action, the muscarinic cholinesterase they activate the inhibitory GI type of G protein coupled receptor, thereby it stimulate the phospholipase C activity, which will increase the metabolism of phospholipid, leading to production of inositol triphosphate and diacylglycerol, which are the secondary messengers, which will help in mobilization of the calcium from the sarcoplasmic reticulum as well as endoplasmic reticulum. Along with there will be activation of the protein kinase C. This will help in the activation of the muscarinic cholinesterase mediated responses. So this leads to opening up of smooth muscle calcium channel and also the influx of extracellular calcium. In addition to this, it also increases the potassium flux leading to cell hyperpolarization, and also it inhibits the adenyl cyclase activity as well as cyclic AMP accumulation, which are induced by other hormones like catecholamines also. So coming to the mechanism of action of nicotinic receptors. So nicotinic receptor functions as a cell membrane ligand gated ion channel ports where upon interaction with acetylcholine, so this receptor undergoes conformational changes and they results in opening up of the sodium channel leading to influx of sodium leading to membrane depolarization of the nerve cells as well as skeletal muscle nerve endings. So indirectly acting parasympathomimic agents will inhibit the acetylcholinesterase level leading to increase in the acetylcholine levels at the synapse which can act on both muscarinic and nicotinic receptors. So coming to the administration part, the directly acting muscarinic agents can be administered either topically as ophthalmic preparation, example is pilocarpine and carbachol for the treatment of the glaucoma as well as to prevent the iridocorneal adhesions, alternatively with the miotic drugs as well as the mydriatic drugs. So orally, methanocol and pilocarpine can be given. Parenterally, again methanocol can be given. So indirectly acting cholinesterase inhibitor can be given topically, orally as well as parenterally. So coming to the pharmacokinetic part of the acetylcholine. So acetylcholine is formed from the choline and acetyl coenzyme A with the help of the rate limiting enzyme, that is choline acetyltransferase, which finally gets settled in the nerve ending vesicles. So like acetylcholine, even the methacholine, carbachol and methanocol are poorly absorbed from the oral route and have limited penetration to the CNS. So pilocarpine being a lipid soluble, they can be easily transferred or penetrating into the blood-brain barrier, and after release from nerve terminals, usually the acetylcholine gets rapidly metabolized by the plasma acetylcholinesterases into choline and acetate, and choline will be taken for again the fresh cycle for the synthesis of acetylcholine. So effects are terminated by acetylcholinesterases and pseudocholinesterases. So methacholine as well as particularly carbachol and the methanocol, they are resistant to the action of the choline esterases. This you need to remember. So coming to some of the MCQs which we can discuss to know whether we have learned some information from this class. A 52-year-old woman is noted to have open angle glaucoma. She inadvertently applies excessive pilocarpine to her eyes. This may result in which of the following? Does it cause bronchial smooth muscle dilation? It causes bronchial smooth muscle contraction. So decreased gastrointestinal motility? No, it increases gastrointestinal motility. Dilation of the blood vessels? Yes, it causes dilation of the blood vessels by releasing the nitric oxide from EDRF. Does it cause mydriasis? No, it causes meiosis. The answer is dilation of the blood vessels. So next is muscarinic cholinergic agonist activates inhibitory GI, decreases production of IP3, decreases release of intracellular calcium, and inhibits the phospholipase activity C. So option B, it increases IP3, it increases intracellular calcium, as well as it will activate the phospholipase C. Here the correct answer is it activates the inhibitory GI coupled receptors. So cholinesterase like carbachol are most likely to cause which of the following adverse effects? Does it cause dry eyes? No, it increases secretions. Does it cause delirium? No. Does it cause salivation? Yes, it causes salivation because of increase in the exocrine gland stimulation by the M3 receptors. Does it cause tachycardia? No, it causes vasodilation, and it causes the decrease in the blood pressure, as well as it causes depressant action on the heart. It causes bradycardia. So this is the nutshell in revising the drugs which are used as a cholinergic agent or cholinomimetic agents. Here we have a pilocarpine, carbachol, methacholine, as well as the methanocol under the directly acting cholinergic agents or cholinomimetic agent, and indirectly acting cholinergic agent we have a neostigmine, physostigmine, pyridostigmine, edrophonium, etc. One should remember that for the overdose of any of these cholinergic drug, you can use the atropine as an antidote. And also one should remember the uses and the adverse effects. And the rivastigmine and galantamine, donepezil are also the indirectly acting cholinergic agent which are used in treatment of Alzheimer's disease. So the questions to answer at the end of this session would be: why acetylcholine not used clinically? Because it rapidly hydrolyzed by acetylcholinesterases. Cevimelin is used where? In the Sjogren syndrome. It is a congener or derivative of the pilocarpine which is longer acting, and Accusert contains the pilocarpine which is mainly used in the treatment of glaucoma for 7 days. What is the effect of pilocarpine on pupil? It causes meiosis, that is the constriction of the pupil. Methanocol uses, they are used in postoperative urinary retention as well as postoperative paralytic ileus. That's why the mnemonic you can remember B for BB. So bowel and bladder atony. Methacholine, they are used for bronchial hypersensitivity tests which are obsolete now. So carbachol specificity and use, they are non-selective, they can act on both nicotinic as well as muscarinic, they are used in glaucoma. So directly acting nicotinic agonist example is nicotine, and selective partial agonist alpha 4 beta 2 nicotinic receptor is the varenicline. So varenicline is mainly used for as a smoking cessation agent. So drug which is used to diagnose myasthenia gravis is edrophonium. Drug which is preferred for the treatment of myasthenia gravis is neostigmine and pyridostigmine, but not the uh, physostigmine. So neostigmine and pyridostigmine has got the good peripheral activity at the skeletal motor nerve endings. So quaternary amine containing acetylcholinesterase inhibitor is neostigmine and pyridostigmine, and tertiary amine containing acetylcholinesterase inhibitor which can cause blood-brain barrier is physostigmine. Longest acting cholinesterase inhibitor is the ecothiopate which acts for 100 hours, and shortest acting cholinesterase inhibitor is the edrophonium which acts for 5 to 15 minutes. So carbachol acts on which receptor? They can act on both muscarinic and nicotinic because of their non-selective action, and methacholine and methanocol acts particularly on only on muscarinic receptor. So which two choline esters are not susceptible to cholinesterases? That is carbachol and the methanocol. So even the methacholine for an extent. Drug to reverse the cholinergic activity is atropine. So coming to the case scenario, the summary is the 25-year-old woman is diagnosed with myasthenia gravis and treated with pyridostigmine. So edrophonium test and diagnosis. So edrophonium is used to diagnose the myasthenia gravis. It is given intramuscular or intravenously injection because of the shorter duration of action. So it will going to elevate the ptosis, that is the drooling of the eyelids, by temporarily increasing the availability of acetylcholine at the synapse, and also allows the contraction of the levator palpebral superioris muscle, and is very specific test for diagnosis of myasthenia gravis. So please remember, edrophonium is used for diagnosis of the myasthenia gravis from the cholinergic crisis also. If when you give edrophonium the muscle power improves, it means the patient has got myasthenia gravis. If the muscle strength decreases, then it indicates that the patient is having cholinergic crisis, that is the excess of cholinergic activity. So mechanism of action of hydrophonium pyridostigmine, it is a acetylcholinesterase inhibitors. So pyridostigmine is used for the treatment, for hydrophonium is used for the diagnosis. So myasthenia gravis in glimpse, myasthenia gravis is an autoimmune disorder where there is autoantibodies against the acetylcholine receptor, which targets mainly the nicotinic receptor present on the motor end plate of the skeletal muscle. And over the time, the number of acetylcholine receptors in the synapse will significantly get reduced. And this is characterized by mainly weakness and the fatigability of the skeletal muscle, ocular problems like diplopia, ptosis, and the proximal limb muscles of respiratory will be affected very often, and symptoms typically fluctuates throughout the day. It may worsen in the evening with the exertion. It may get relieved with the rest. So thymus is the one which is responsible for generation of the auto antibodies, and symptoms are often relieved by thymectomy. So acetylcholinesterase inhibitor will be the mainstay of treatment for myasthenia gravis. You can use either the neostigmine or the pyridostigmine. So what is the advantage of using pyridostigmine? Pyridostigmine is a longer acting agent compared to the neostigmine. Thank you.